So let me share my screen. We're going to now cover intraoperative nursing care. Let's see. So this would be chapter 19. And a lot of this chapter is covering anesthesia, which you are going to cover in chapter 11 in Lilly in pharmacology. So I'm not going to focus so much on that as the nursing care piece of it. And so when we're talking intraoperative care, we're talking about in the OR, which takes place in the OR. There are a lot of different outpatient settings now, but they have some type of operating room. But there's also things, we have a lot of different laparoscopic things, endoscopies that are done that are also minimally invasive surgeries. For example, appendectomies, we used to have incisions and go in for everything, and then now we can do that laparoscopically. And so if we do minimally invasive surgery, it just helps all around. Better recovery times, shorter hospital stays, less pain. Incision size is often smaller. Like for an appendectomy, there'll be three little insertion sites, and that's it, not like a big incision. And that would also promote less blood loss, which is a good thing. And so when you're talking about surgery, that's a surgical department. When you're in the OR, it's a very controlled environment, sterile environment. So there's not a lot of pathogens. And then because it's a safe surgical area, everybody follows the rules. And so there's a nice flow of patients and the staff and the equipment so that we're all able to provide safe patient care. There are different zones as you're in the OR or making your way to the OR. So there's what's called the unrestricted zone. And so this is people in street clothes, like you're coming into work. For example, in OB, for example, labor and delivery, the nurses will change into scrubs when they get there, when they get to the hospital. So they'll come in street clothes, we can interact. Everybody can come in the locker rooms, the nursing station, even like the pre-op holding area will be someplace where everybody can come. You don't have to wear any special, PPE or anything unless designated. So that would be your unrestricted zone. And then you have what's called your semi-restricted zone. And so these would be surrounding support areas that only authorized staff should be in, and you should be wearing clean surgical attire, so scrubs, the long sleeve jacket, shoe covers, appropriate PPE, surgical head cover. So I think of this in terms of, I can't remember at SVH, but I know in Natividad we have this area between the nurses station and the OR. And so that's actually the semi-restricted zone. You have to have a surgical head cover and shoe covers on. And you should have, if you don't have scrub attire, you can go there without scrubs on. You should have scrubs, but you can put PPE on, but you're not sterile. You're not in the OR yet. So there's still, it's clean. It's a clean environment. The restricted zone would be the surgical suite when you're in there. There's masks worn. We're trying to minimize the traffic. Everybody has a specific job. Certain people remain sterile, certain people remain non-sterile. You have to be very aware of your environment when you are observing surgery, that you're not backing into a sterile setup, sterile tray somewhere, or somebody's asking you for something, somebody wants you to tie their gown. There's ways to do things like that. All the equipment in there has been sterilized. And then after the surgery occurs, then the environmental services cleaning crews come in and do specific cleaning for the OR. They have to sanitize. But we should not be going in the OR without the proper coverage, the head cover, gloves, our gown. We should put a gown on. And so the pre-op holding area we said was the unrestricted zone, and then admission, observation, and discharge unit. So it depends on how how it's set up. But outpatient same-day surgeries, those would be clean areas. And then we're going to talk about our client here scheduled for surgery. So 56-year-old male comes to the surgical suite with his girlfriend morning of his surgery to replace his left knee. So he's getting a left knee replacement. He has osteoarthritis in the left knee and has a history of hypertension. So we should be thinking of some questions that, not questions because we're not pre-op, but things that we want to know when he's coming to us in the OR. And so in the operating room, as we said, that was the restricted zone. It's aseptically controlled. Usually the PACU is right next to it. And so everybody's like right there. If there's an emergency, everybody's there to come together and collaborate. So in the operating room, there's controlled airflow and filters. It's very temperature and humidity controlled. Usually I think surgeons like to keep it a little cool, and as I was also saying, there's strict protocols for environmental services when they do their cleaning of the operating room after surgery. And they're always doing checks on the equipment. The lighting actually has like sterile handles, and so you can use your sterile gloves to move it. Or what we have in L&D is like a light. It's like a remote control, and it can move the light so it can focus on the perineum when they're doing deliveries. That's kind of cool. We also want to look at who is on the surgical team. Who is there? So you have perioperative nurse, registered nurse, works with the rest of the surgical teams. They can be the pre-op, the post-op, or in the operating room. They're a patient advocate. You've got the scrub nurse. Now, the scrub nurse is sterile. They're going to follow the surgical hand asepsis. They're gowned, they're gloved in sterile attire, and they are going to help prepare and manage the sterile field and the instruments for the surgeon and the surgeon's assistant. Then you also have a circulating nurse. Circulating nurse, they're in the unsterile field. That's why I kind of, circulating, because they're going a lot of different places. The scrub nurse is pretty much going to stand in one place with the instrument tray and be handing the sterile equipment, handling the sterile equipment. The circulating nurse is usually the one that will keep documentation. Oftentimes the charge nurse will serve as the circulating nurse because they have to have somebody that's documenting as well. So they all have specific roles in the OR. You could have a VN that fills that role. The RN would have to supervise. You can also have scrub techs. So it doesn't have to be a VN, it would be a tech, but they will come in and open the OR and get all the instrumentation ready but once they're in there, they're sterile. And so then they have to call if they need somebody to get them something because they can't break sterile. And you have the surgeon, the physician who does the surgery. They're getting the histories, doing the assessments, which the pre-op nurse is doing as well. But they're going to give us all our orders, post-op management, their job to get the informed consent, and they're the leader. They're the one leading the surgical team and the surgery. There can also be a surgeon's assistant, can be an RN first assistant or a PA, and they like hold retractors. They help with suturing, and then they might also perform some of the procedure under the direct supervision of the surgeon. And you'll see that in C-sections for sure. And then the first assistant works with the surgeon. An RNFA that you can get certified as a first assistant. That's kind of a cool job. And so then we progress. We've got the anesthesiologist meeting with our client in the holding area to assess and obtain informed consent for the general anesthesia that they're going to receive. And so you've also got the anesthesia care provider as part of the surgical team. They are going to administer, obviously, the anesthesia. They are not considered sterile. They sit behind the client at the head of the bed. And they are really managing the vital functions. They're looking at the monitors. It can also be a nurse anesthetist, but they are in charge of the vital signs and the breathing and how's everything going anesthesia wise. And then we have the nursing management. What do we do in terms of nursing care prior to and coming into the OR? So we talked about already, we've done the pre-op assessment. That was in the pre-op PowerPoint. So I'm kind of run through those because we went into that already. And then we're in the holding area waiting to go into the OR, and our client appears anxious and is kind of reluctant to answer questions that we're asking. It's the first time that he's having surgery, and he says he's got pain of 6 out of 10 in the knee. So I'm thinking psychosocial pain and psychosocial are big priorities right now. And so as we're getting ready to go in, we're going to answer any last minute questions, make sure that like the dentures, the glasses, all those things have been removed, ask about when their last food and drink was, any pre-op drugs that were given, and we put a hair cover on the patient as well, because we don't want any hair floating around in the sterile environment. Checking on any complementary or alternative therapies. And so when we get the client, when the client's in the OR, the circulating nurse really is the one that sort of, the surgeon runs it, but the circulating nurse is really, implementing the plan of care. So looking at the client, reassessing everything, kind of keeping an eye on everybody and making sure things are going smoothly. Making sure that the equipment is, the room has been cleaned, the room is prepped, things are where they need to be. It's also like, do you have the right bed if it's a person that's obese? Do we have the right bed that's in the OR? Or is there any special equipment that we might need for a specific client or a specific type of surgery? So making sure that all that is there. Always do your safety checks, and then you're going to count. We want to know, the scrub needs to know what you're starting with, and then we count so that we know what we end with. So we make sure we don't leave anything inadvertently inside the client. And we'll do counts. They'll actually keep track and they'll call them out. Sometimes they have to go back in and find things. And so, yeah, we're checking the vital signs. They're transported into the OR. They'll often transfer from the gurney to the bed, so make sure the wheels are locked, and lots of good communication when you're moving the client over. They'll have safety straps to keep them secured to the bed, not too tightly, and we're monitoring the vital signs. And so our client's getting ready to go to the OR. The surgeon comes in and marks his left knee. He has an anti-embolic stocking on his right leg, an IV of D5.5 in the right hand. He's got orders for cefazolin and insertion of a urinary catheter. So kind of be thinking in your mind, like, why do we need the catheter? What do we have the IV? I don't know the rate of the IV. It's probably going at 100. Why do we need the antibiotic? Like all those kind of things. And then before, like the surgeons, when you're going in, and I know as a NICU nurse, I would scrub as well. So we do the fingernails and up to the elbows. We do this in NICU too. The nurses in NICU will scrub. And then you can use the waterless alcohol-based agents, but you're definitely going to have to wash and clean your nails. And they have specific scrub brushes and nail files for that. And then the sterile gown. And usually they'll do 2 pairs of gloves. And then once you're sterile, you have your sterile gloves, you can touch the other sterile items, sterile to sterile. And so this is one of the reasons that we're trying to teach you about sterile, non-sterile, so that you can function safely in these types of environment. Standard transmission-based guidelines from OSHA and the Association of Operating Registered Nurses. Right, using personal protective equipment, only sterile items on the sterile field. And always be looking around so you know where your sterile field is so that you're not contaminating. Because if you contaminate one little thing, then it's like you have to start over. It's not fun. You also could have an assisting anesthesia care provider that will help the anesthetist. They can do vitals, measure the blood pressure, look at that, make sure the airway's open. They can be a liaison between the anesthesiologist and other people, other team members. And we want to make sure that we're positioning the patient appropriately. So depending on where their surgical site is going to be, the type of surgery that we're doing, they could be prone. They could be face down. If we're going in through the back, then they're going to be face down, and that provides other challenges than if they are supine or on their side or whatever position that they're in. We want to make sure that we have access to the operative site, and we of course can maintain the patent airway, which would be the anesthesiologist's job. We don't want undue pressure. We want to make sure that they can expand their lungs and that they're positioned in correct alignment. But we also want to make sure that there's padding and support, make sure the extremities are secured as much as we can. And then, there's a grounding pad for the electrosurgical equipment so that you don't get burns or have fires start. Position changes. And the other thing in C-sections is that the support person can come into that sterile environment, but we make sure that they have, we call it a bunny suit at Natividad, but they have to put a gown or something on. They have to cover their hair. They wear a mask. So they have to go into that sterile environment with the correct PPE. So they transfer our client to the OR table, and the circulating nurse is going to start to prepare him for surgery. And so they usually have to do some kind of scrub or cleanse around the surgical site. You're going to go from clean to dirty. You want to make sure that it dries fully, and then they'll drape the site. So depending on the site and the type of surgery, I know for C-sections they'll scrub and they'll scrub the site and then put the sterile drape over. They might also be inserting Foleys. I know for C-sections that's what we'll do once they transfer the client to the OR table, then we can insert the Foley. And now the nurse is going to prepare the leg for surgery. And so we should also be thinking about communication, infection, things, that we need to be the safety piece of it, any trauma to the leg that might happen. And communication, teamwork is just so important. And so the pre-op nurse will then generally give report, or the holding room nurse will give report to the OR. And usually we'll have a prophylactic antibiotic prior to the surgery. The warming blankets are great. You might put on, they call them IPCs, intermittent pneumatic compression devices. So that would be like your sequential compression devices, just a newer term. And we're going to look at the National Patient Safety Goals in different surgical settings. That's on your lesson page. And so we have to verify the documentation, the studies, any blood products, and the surgical site marking is one of the big patient safety goals, that you're doing the surgery on the correct surgical site. And then when the surgery is done, the anesthesia care provider is going to anticipate that. And so they'll start to wean the anesthesia. And then the client will go to the PACU, and you'll have another S-bar, the handoff there to the PACU nurse. We talked about that in the post-op PowerPoint. And so now the surgery is completed, client's transferred to the PACU. He has a drain in the left knee. The left leg is wrapped with an elastic bandage from ankle to thigh. He has a non-rebreather oxygen mask on at 100%, and IV is infusing at 100 mLs per hour. So basically, he's gone to PACU, and we already talked about PACU. That's in the other PowerPoint. So the next section of slides has to do with anesthesia. So I'm just going to briefly go over. I'm going to run through the slides. You can look at them on your own time, but you will cover this in pharmacology. And so sedation, different types of sedation, inhalation agents, general anesthesia. So for C-sections, they're doing an epidural or sometimes a spinal, not general, unless it's an emergent situation. But a lot of those the surgeries that we've seen in these case studies in the PowerPoints would be general anesthesia and probably some type of balanced anesthesia. Intubation is always tricky. So you can have laryngospasms. The adjuncts, you can do dissociative agents like ketamine. We use those a lot when we would do burn dressing changes for our pediatric patients when I was at Shriners. Other adjuncts would be opioids, the benzos, sometimes neuromuscular blocking agents. Those are really helpful to facilitate the endotracheal intubation. And you'll learn about those in pharm. But if you have a neuromuscular blocking agent, like they can't move. The client can't move. So you really have to be watching the airway and their safety because they don't really have any way to move. Antiemetics as adjuncts. You can also have local anesthesia given by different routes. You can do regional, which is a block, a certain area of the body. It can be used pre-op, during surgery, or post-op. It's a rapid recovery. There's not cognitive dysfunction. So this is regional anesthesia would be like an epidural, for example. So there's not a lot of systemic absorption necessarily. But there are some disadvantages. Could be possible technical problems. Topical, sometimes for starting IVs, we'll do like an EMLA cream, a topical cream, so that we can start the IV and they don't feel the pain necessarily. And then regional nerve blocks and properly positioning the patient so that they can get the needle and the catheter in the right spinal space. And so spinal anesthesia would be local anesthetic into the cerebrospinal fluid in the subarachnoid space below level 2, and you have you're blocked below that level. And then epidural is into the epidural space, not the other space. And so it doesn't go into the cerebrospinal fluid. So the sensory pathways are blocked, but the motor fibers are still intact. And so that's why the mom can still push because it's harder because the sensory pathways are blocked, but you would be able to move your legs kind of sort of with a lot of thought. And so you're looking for bradycardia, hypotension, nausea, and vomiting. Those are always big things. And then you've got your, again, your gerontological considerations, which we talked about in other PowerPoints. And then you're always on alert for anaphylactic reactions. Might see that with anything, as well as the hypotension, tachycardia, any respiratory problems. So malignant hyperthermia This is characterized by hyperthermia with skeletal muscle rigidity. So the muscles will get really rigid. It's actually an autosomal dominant trait. So that's why we like to ask the question when we're doing that pre-op assessment, if there's anybody that's had this, how people react to surgery. And you get muscle contraction, hyperthermia, hypoxemia. You can have hemodynamic, like blood pressure problems, cardiac problems, and dysrhythmias, which is not a good thing. And so one of the triggers is something called succinylcholine, which is given with the inhalation agents often, and that's a big trigger. But sometimes it can just be the stress of the surgery, the trauma, if the OR is too hot. But it generally occurs during the general anesthesia part. It could happen in recovery, so we should be looking for it post-op, but it usually happens in the OR with the general anesthesia. And it's diagnosed after ruling out other causes. The body temperature rising is not actually an early sign, it's a late sign, but it is a very dangerous situation. And so we'll give dantrolene, and which will reduce the muscle contractions, and then 100% oxygen and actively cool the patient. So the anesthesiologist is doing a lot of that, or maybe his assist, because he's giving the dantrolene, he's going to help provide the oxygen because he's at the head of the client. And then we can help, the rest of the team can help cool the client as well. So that's why it's important to do the family history. And the person may not know, and that's okay, but we should be asking for sure. And so a couple of practice questions here before we go. During admission of the patient to the holding area or the operating room before surgery, the perioperative nurse must. What must we do? We must verify the patient's understanding of the risks of surgery, ensure the patient's identity with a formal identification process, prepare the skin by scrubbing the surgical site with an antimicrobial agent, perform a pre-op assessment with a patient history and physical examination. So they're coming into the OR from pre-op. What's the first important thing that we need to do? We need to ensure the patient's identity with a formal identification process. And what they'll do in the OR is they'll actually do something that's called a timeout procedure. I think some of you that have been in C-sections and other surgeries might have seen this, where everybody stops. It's usually the circulating nurse that will say we need to do the timeout, and they will verify that the client who is still awake at that point, their name, date of birth, the surgery, they'll verify the surgical site. And it's just a double check that everybody's on the same page. We have the right person and the right body part, and we're doing the right surgery. And that is called a timeout procedure. During the administration of any regional anesthetic, it is most important that the nurse monitor for ascending neurological depression and unconsciousness, ensure that airway equipment, emergency drugs, and monitors are immediately available, monitor the patient's response to the anesthesia, assessing the extent of loss of sensation, ensure that reversal drugs such as neostigmine are available in case of respiratory arrest. So of these things, which is the most important that we, the nurse, do during the administration? Monitoring the anesthesia and the neurological depression, that's really the anesthesiologist. We want to make sure that any reversal agents are available, but really we want to make sure that the airway equipment, emergency drugs, and monitors are immediately available. That's part of our job as the nurse, to make sure that the things that need to be in the operating room are there, and that they work, that the intubation equipment is there, that drugs are there, and there's monitors that are immediately available. And so that brings us to the end of our intraoperative PowerPoint. So key points to take away from this would be what everybody's role is in the OR, and in terms of PPE, when are you wearing, which is the sterile area, which is not the sterile area. And then things such as the malignant hyperthermia, like how would you recognize that? What would what are your interventions for that? And we will, of course, go over the objectives in class. And you can, review the recordings as needed. And thank you very much.